disease. Now, if you see the causes of primary adrenocortical insufficiency or Addison's disease, again, this used to be one of the favorite PPG questions. In India, tuberculosis is the most common cause. In Western world, autoimmunity is the most common cause. So you must understand and read the text carefully, which is framed while framing your multiple choice question, whether it's a generalized most common cause of adrenal insufficiency, or in the end it is written in India. If it is in India, then tuberculosis of adrenal gland is the most common cause of adrenal insufficiency or Addison's disease. In overall or otherwise in West, it is autoimmunity. Apart from that, hemorrhage, metastasis, various drugs like etomidate, ketoconazole, metairopon. We take help of these drugs when we are treating Cushing syndrome. In secondary causes, any pituitary disease causing hypopituitarism will result in secondary adrenocortical insufficiency. Now, in Addison's disease, which is a primary disorder, when cortisol is not secreted from adrenal gland, so there will be a loss of negative feedback loop. If you remember the last class, cortisol exert negative feedback loop over pituitary and hypothalamus. The result is secretion of high amount of ACTH. Now, when ACTH is secreted in huge amount, it contains a sequence which is known as MSH sequence. Now, this melanocyte stimulating hormone, which is present inside ACTH sequence, will act on your skin and will result in skin hyperpigmentation. So, patient has low adrenal androgens and skin hyperpigmentation. So, an important differentiating feature in contrast to ectopic Cushing syndrome, where again skin hyperpigmentation happens because of very high amount of ACTH, is high cortisol in those patients where cortisol levels are low. Also, these patients are having hypotension, that is, blood pressure is low, in contrast to hypertension in ectopic ACTH syndrome, and patient is having weight loss. So, if you see a patient who is having hypotension, skin pigmentation, weight loss with low glucocorticoid level, you should have index of suspicion for Addison's disease. In fact, a dictum is if systolic blood pressure is more than 110 millimeter of mercury, Addison's disease is not present. So most of the time, if you see a patient of Addison's syndrome, the blood pressure is 100 or 90 millimeter of mercury. Now let's look at clinical signs and symptoms. If we see the symptoms, in 100% of the patients, they have nausea, vomiting, anorexia, loss of weight. In fact, gastrointestinal symptoms are present in more than 90% of the patient, including abdominal pain, which is seen in around 30% of the patients. You will be surprised to know we have seen patients who are referred as an acute abdomen and medical emergencies, or who has been started on some drugs for management of abdominal pain, nausea and vomiting without making a diagnosis of adrenal insufficiency. Diarrhea is again a presentation because of cortisol deficiency. Salt craving is seen, postural hypertension is present, and wakes, muscle pain, joint pain is present in good number of patients. If we see the signs, as I have told you, weight loss is present in 100% of the patient. The next common sign is hyperpigmentation. I have told you, if blood pressure is more than 110, it rule out adrenal insufficiency. So BP, systolic blood pressure, has to be less than 110 millimeter of mercury. In 10 to 20% of the patient, along with hyperpigmentation, there is vitiligo patches, because the most common cause is autoimmunity, and vitiligo is an autoimmune disorder. So again, an important catch. If you see an individual with hyperpigmentation and vitiligo in a same patient, you should rule out adrenal insufficiency. Auricular calcification is peculiarly seen in patients of adrenal insufficiency. Now, if we see, I have discussed you what are the features of adrenal crisis, because if somebody who is taking exogenous steroids from a long period of time and now you suddenly stop it, patient may go in adrenal crisis. So patients presents to you with dehydration, hypotension, and shock which is out of proportion to severity of current illness. Means patient is otherwise looking well, but when you have measured blood pressure, it is coming to be 80 systolic, 84 systolic. So your shock is out of proportion to severity of illness. Patient is having history of nausea, vomiting, there is history of weight loss, anorexia. I have told you about acute abdomen, unexplained hypoglycemia, because cortisol is one of the counter regulatory hormones. So if it is deficient, patient will have hypoglycemia, patient have unexplained fevers, hyponatremia, hyperkalemia, azotemia, hypercalcemia, and incomplete blood picture, eosinophilia. These patients have hyperpigmentation and sometimes rare patients coexistence of hyperpigmentation and vitiligo. And if patient is having other autoimmune endocrine disorders such as hypothyroidism or gonadal failure. So these are the features which are seen in patients who come to you with adrenal crisis. What are the investigations? I have already told you. Patients have hyponatremia, hyperkalemia, hypercalcemia, azotemia because of dehydration, anemia, and eosinophilia. What are the emergency measures? Now, immediately, if you have a suspicion, first step is drawing blood sample. Because if you will give steroid, you will not be able to make diagnosis after that. Exogenous steroid is going to interfere with your estimation process. So take a blood sample immediately, store in the fridge, and then pending the laboratory results, you should infuse normal saline, which is NaCl, along with intravenous hydrocortisone. 100 milligram of intravenous hydrocortisone is given immediately and then every 6 to 8 hourly, and you should wait for the result. If the report is suggestive of adrenocortical insufficiency, you should continue steroid over a long-term measure. After stabilization of the patient should be shifted to oral glucocorticoid therapy. In patients who are having primary adrenocortical insufficiency, it means Addison's disease, they need both glucocorticoid and fludrohydrocortisone, which is mineralocorticoid support, along with dihydroepiandrosterone sulfate administration, because the entire adrenal gland is diseased. But in those who are having secondary adrenocortical insufficiency, fludrohydrocortisone might not be needed, because again, I have told you in last class, the mineralocorticoid axis is under control of RAS system. I've told you how to give oral. You can give hydrocortisone as an oral dose. Because of circadian rhythm, 2/3 of the dose is given in the morning, say 8 a.m., and 1/3 of the dose is given in the evening, which is around 4 p.m. Fludrohydrocortisone, liberal salt intake in those who are having primary adrenocortical insufficiency. Now, like in India, we are going in a summer season with lot of perspiration. In these times, patient has to be take liberal salt intake, and fludrohydrocortisone dose needs to be optimized in patients of primary adrenocortical insufficiency. Now, coming to the third part of the lecture, before we finish adrenal disorders, endocrine hypertension. Now, this is a very important topic. This is classification of hypertension, which I'm not going to discuss in detail, but in 2017, in contrast to previous classification, it is simplified. There is stage 1, stage 2 hypertension only, and this is probably going to be discussed by some of the teachers in cardiovascular system. But good number of patients, 1/3 of the population is suffering from hypertension. And if we see, 85% of them are caused by primary causes or idiopathic hypertension, but 15% are secondary hypertension. And what is important, if we diagnose this 15%, we can treat hypertension permanently. Patient does not need any drug. And if we see, there are renal causes for it, which is renal parenchymal disease, renovascular disease. There are endocrine causes of hypertension also. And at least 15 endocrine disorders will cause endocrine hypertension. But I will not discuss all 15 with you. They are beyond your scope. We will discuss in brief about Cohen syndrome and pheochromocytoma. What is important to understand is majority of endocrine hypertension are treatable. Unfortunately, because of lack of understanding, we do not pick up them. And when we are not picking them, we cannot offer them treatment in right time. There are cardiovascular causes of hypertension, and there are some other causes like obstructive sleep apnea, drug-induced chronic alcohol abuse. Now, more than 50% of the children who presents to you with hypertension have secondary hypertension. In young age and in elderly, prevalence of secondary hypertension is around 30%. So if you see a hypertension in anybody who is less than 20 years of age, or those who are more than 50 years of age, secondary hypertension should be ruled out. Essential hypertension, which is responsible for majority of cases, has a middle-aged onset. Now, what are clues to identify endocrine hypertension, which is my topic? As I have told you, what are clues to identify or have an index of suspicion for Cushing syndrome? So if you see hypertension in young without family history of hypertension, it means less than 20 years of age. Here it is written 30 years of age. index of endocrine hypertension should be kept. If you see anybody who is coming to you with hypertension and hypokalemia, even somebody who's using diuretic, if there is hypertension and hypokalemia, you should rule out endocrine hypertension. If you see severe hypertension on drugs, that is more than 160 systolic and more than 100 diastolic. If you see resistant hypertension, what is definition of resistant hypertension? Again, all these things are probably discussed by somebody in cardiovascular system. Patient who are having poorly controlled blood pressure despite taking 3 antihypertensive drug. Out of these 3 drugs, one should be a diuretic. If patient has fluctuating hypertension, means blood pressure sometime becoming normal on his own, and patient have episodes of anxiety, sweating, tremors and palpitation, spells. This is classical triad, which is seen in pheochromocytoma. If patient has hypertension as well as signs of virilization, especially they are coming common in females, they are coming to you with increased beard, mustache and hypertension. You should rule out endocrine hypertension. Hypertension in an adrenal incidentaloma, hypertension and obstructive sleep apnea, hypertension and a family history of CVA at an age of less than 40 years of age. So if there is a family history of cerebrovascular accident at less than 40 years of age, now somebody is coming to you with hypertension, you should rule out endocrine causes of hypertension. And then positive family history of endocrine disorder means in family, if there is history of MEN syndrome, multiple endocrine neoplasia, pheochromocytoma, thyroid disease, etc., they are pointer that it might be because of secondary cause or endocrine hypertension. So this is a very important slide, how to have index of suspicion. Now, this is a list of endocrine causes of hypertension. As I told you, there are more than 15. I'm not going to discuss with you. This is beyond you. But we are going to discuss with you two important diseases, which as an MBBS student, you must know, pheochromocytoma and Cohen syndrome, which is primary hyperaldosteronism. Now, what are the clinical features where you should have index of suspicion for primary hyperaldosteronism, which is also known as Cohen syndrome? Now, an interesting fact I will tell you, 10 years back, it was believed that this is a rare disorder. In fact, when I was an MBBS student some 30 years back, we were never taught about Cohen syndrome. And we never used to read about all these things. But over last 10 years, it has been recognized that among endocrine causes of hypertension and secondary causes, Cohen syndrome is one of the most common cause that is responsible for as much as 10% of the patients of secondary hypertension. So we must know about this. These patients will have hypertension and hypokalemia, resistant hypertension is severe. Often patients present and hypertension. We have published this case from our own institute, and this is quite common in Asian population. So if you see a patient coming in emergency with paraplegia, hypokalemia, and you have measured blood pressure and hypertension is present, then you must rule out primary hyperaldosteronism. Patient can have tetany associated with decreased ionic calcium because of metabolic alkalosis, which is seen in primary aldosteronism. These are some of the general clues. But remember, hypokalemia is seen in only 1/3 of the patients, so it is not seen in everyone. And primary hyperaldosteronism, why it is important to identify? Because it has been found that it is associated with very high risk of cardiovascular event, including stroke, AF, myocardial infarction, in contrast to people who are having essential hypertension. Now, there are 3 steps in evaluation of primary hyperaldosteronism, as we have discussed with Cushing syndrome. First is a case detection test, means screening test. Then second is confirmatory. Now you have detected a case, you have an index of suspicion. Now you should do a confirmatory test. And then there are some rare subtyping tests, which you must know theoretically. Now, if case detection test, we have to measure plasma aldosterone and plasma renin, and we have to calculate aldosterone renin ratio. Now, in a case of primary aldosteronism, plasma aldosterone will be more than 15 nanograms per deciliter, and renin will be suppressed, because when aldosterone levels are high because of negative feedback loop, it will cause suppression of renin levels. And aldosterone and renin ratio is more than 20. So this is case detection or screening test. Next is confirmatory test, where we perform some suppression test, like giving 2 liters of 0.9% sodium chloride, which we have discussed in last class. Then we measure plasma aldosterone level. Again, the levels we have discussed in last class. If the values are more than 10 nanogram, it is primary aldosteronism. If they are less than 5 nanogram, they are normal. Between 5 to 10 is a borderline zone where we have to do some other investigations. Adrenal venous sampling is not performed in everybody, but there is a role when you have on imaging a solitary hypodense unilateral macroadenoma, means more than 1 centimeter but less than 2 centimeter, with contralateral gland which is normal, and your plasma aldosterone concentration is more than 30. There is no need to perform adrenal venous sampling. But if you have microadenoma which is less than 1 centimeter, if CT show bilateral normal adrenal gland, or if there is minimal unilateral adrenal lymph thickening, these are the cases where adrenal venous sampling should be performed. What are principles of treatment? If you have localized an adrenal tumor, surgery is a treatment of choice. If you have failed to localize an adrenal tumor, then we have pharmacological treatment. The drug of choice is mineralocorticoid receptor antagonist. We have two important drugs, spironolactone and eplerenone. Now, spironolactone has a side effect of causing gynecomastia in males. So if we are seeing a male, eplerenone become a choice over spironolactone for treatment of primary hyperaldosteronism. All patient does not have resolution. Few patients have persistence of hypertension. So if they have persistence of hypertension, then we should rule out some other things. Now, lastly, pheochromocytoma. Now, what are the features where you should have index of suspicion for pheochromocytoma? If patient presents to you with headache, palpitation, sweating, along with hypertension, this is now known as spells. If patient is having spell along with hypertension, we should rule out pheochromocytoma. These patients can also present to you with nausea, vomiting, pallor, tremors. Now, there are various other signs and symptoms which are associated with hypertension. They can be seen. As you see in this imaging, pheochromocytoma is associated with a big adrenal adenoma, in contrast to majority of adrenal adenoma, which are small in size in Cohen syndrome. Also, there are some syndromes like MENS 2 syndrome, multiple endocrine neoplasia type 2, neurofibromatosis type 1, von Hippel-Lindau syndrome, and Carnage triad. They are associated with pheochromocytoma. Now, you must at your home read about these syndromes and their association with pheochromocytoma, because these are some of the favorite pre-PG questions where 2 or 3 or 4 things are mentioned that which is not present in MEN2 or neurofibromatosis. So pheochromocytoma is seen with these disorders. How to treat pheochromocytoma? I have told you, you have to localize where is a tumor. Now, surgical treatment is a treatment of choice. Before surgery is performed, you have to do a pre-operative preparation. Now, for doing pre-operative preparation, you have to give an alpha-adrenergic blockage. Phenoxybenzamine is a non-specific alpha-1 and alpha-2 blockage. It's a drug of choice. But unfortunately, it is not freely available. If it is not available, you can give selective alpha-2 blocker, which is prazosin. After an alpha blockage is achieved, and how it is achieved? When patient develop some orthostatic hypotension with tachycardia, then you should add beta blockage. Beta blockage can be done with bisoprolol, with labetalol. On preoperative table, even esmolol can be used. If while doing operation, patient develops severe hypertension, then for management of hypertensive crisis, phentolamine and nitroprusside is used. Sometime in post-operative period, patient develop hypotension after removal of the tumor. In those cases, we need to give IV fluid for management of hypotension. Now, if you have to manage pheochromocytoma, remember beta blocker without alpha blockage need not to be given. It's contraindicated. It will precipitate your pheochromocytoma crisis or hypertensive crisis. Calcium channel blockers are drug of choice. If patients are having arrhythmia, then lidocaine or esmolol can be used. Lastly, you can have an adrenal adenoma which can be secreting androgens. If there is secretion of androgen, see this is an image of female, which post-operative image, and pre-operatively there is formation of mustache. This is again discussed in last class, so I will not discuss the various steps in enzyme synthesis. If you have deficiency of 21 hydroxylase, cortisol will not be synthesized, and the disease is known as congenital adrenal hyperplasia. Now, this is apparently looking a male, but if you see karyotype is 46XX, means this is a female who is having deficiency at the level of 21 alpha hydroxylase, resulting in deficiency of cortisol over the, oh, sorry. Now, when you have cortisol deficiency, the precursors will be diverted to synthesis of androgens, and the result is hypertrophy of clitoris and male appearing features. This is one of the most common autosomal recessive disorder of human beings, seen with consanguineous marriages. So one should not be surprised by seeing this. So congenital adrenal hyperplasia, you must remember. So any male who is presenting with ambiguity, where both testicles are absent, but you have apparently looking phallus with absence of bilateral testicles and ambiguity, then you should rule out congenital adrenal hyperplasia. So with this, we finishes our adrenal gland, where we have discussed briefly about various adrenal disorders, anatomy and physiology. At your home, revise all these disorders, and in next class we will start with some other endocrine disorder. Thank you. Now log your attendance and leave the class.